afternoon. Once again, back to our channel, KMI Healthcare. Today, we're going to have our speakers today. She's Dr. Lavanya, and on a very relevant topic where affects Malaysians precisely. The topic today is strengthening diabetics management in primary care. Diabetics has been known as a family disease. So much so that if you do have a family history of diabetes, and you are likely to have pre-diabetes and later on develop diabetes in your later age. And according to National Health and Morbidity Survey in 2019, 1 in 5 adults in Malaysia has diabetic type 2. And Malaysia has known to be the highest prevalence of diabetes in Southeast Asia. The highest incidence of overweight and obese people, even children, a very imbalanced diet, and high calories and low fiber are the main contributors to the rise of diabetes in Malaysia. By 2025, that is just 2 years away, Malaysia will have been more than 3 million new diabetic patients. And this number definitely will exhaust our healthcare system, and the country will be unable to afford the cost of diabetic care by then. Diabetes has been in our community for a longest time, but of late it seems to be affecting younger people. As such, there is a need for prevention strategies to slow down the rising of the numbers. And we all agreed that now healthcare system has evolved, and we should, I think, medical professionals, to leverage on technologies as a part of the strategy would be much more relevant now. Let me introduce our speakers today. Dr. Lavanya Narayanan, graduate from MBBS and obtained her postgraduate in MRCP in the UK in 2017. Dr. Lavanya has special interest in diabetes management and metabolic medicine, and she's currently pursuing Master in Diabetic Care at the University of Warwick. She's also an advocate for using digital tools to share health resources and information to help patients to achieve optimal health. In addition to patient care, she is also a medical educator, where she involving mentoring undergraduate physicians and medical students on the path to the MRCP. She is the founders, academic directors, and postgraduate course coordinator of CME Academy, which aims to develop Malaysia's largest online medical library for postgraduates, and in line with digital education and the development of virtual delivery of medical education. She has recently joined KMI Taman Desa Medical Center as a resident internal medicine physician and diabetic specialist. Without much ado, Doctor, the floor is yours.
Thank you very much, Ms. Louie. That was a very humbling introduction. Thank you very much, Dr. T, for having me today to share a little bit about how we could strengthen diabetes care at a primary care level. And today's session is going to be more of like a sharing session. Over the years of my continuous learning in diabetes medicine, my discovery, my observations, and I would like to also include some practical tools that we as doctors can apply in the diabetes management we do every day. So thank you very much. I will start off by sharing my slide. One moment. Meanwhile, I will just share a little bit of what I do. So I'm an internist by training, and I also specialize and hope to complete my specialization in diabetes medicine soon. This is an area that I selected because it's not all so fancy, but it is. I find that it is one of the most important things that we are currently lacking, and there's a huge gap in this area that can be filled. Are you able to see my screen now?
Yes.
Okay, one moment. I think I'm going to put it at presenter view.
Sure. Yeah. Okay, great.
Is it still the main screen?
Yes, still the main screen.
Okay, great. Okay, and right, so going back to where I left, in this journey, I will share with you a confession of mine. In the initial stages of me managing patients with diabetes, and I was from the government setting and healthcare, it was definitely very frustrating due to the sheer complexity of the disease itself. Yeah, and at the moment, how it is slowly creeping and affecting a large group of us is what's becoming more frustrating for practitioners, because when you see patients in the clinic, almost every one of them is probably pre-diabetic, diabetic already, or in the road to going towards diabetes. So in my session today, I'm going to cover four main things. The first of all would be understanding diabetes in a very macro view. So I'm not going to go into the details of the pathophysiology of the disease or how do you diagnose and classify. These things all, they are very, we can refer to them in our CPGs, and they come about time and time again in our practice. So that's the basic knowledge we're already supposed to have. But today, what I'm going to share with you is a very macro view of diabetes. What is the impact of diabetes on a person's life, on a country, on practitioners per se, and an overview of that. Secondly, we'll look into lifestyle modifications. I know we come across this all the time, but it in itself is actually quite specific. I would say lifestyle modification is a prescription that today it has turned into a prescription that doctors ought to know. However, we are still, going in a way where they are providing blanket advices, and that's not really working much with patients these days. Thirdly, we are going to look at health data utilization. So today, if you notice, many of us already have some form of devices or softwares that are able to capture data. Data is something that runs our lives. And what we need to know today as practitioners is science is very closely related to data. So putting all this together, how can we make sense of health data? And how can we make a difference in a person's life is what we are going to look at. And lastly, tech integration. So data alone may not be very complete. How do we use technology today in the 21st century and not miss out on going back to the basics? Using technology is what I'm going to share a little bit in our session today. So again, going back to the macro view of diabetes, I think Ms. Louis has already also given us a very brief introduction. So we are shy 10% away. Okay, we are just 10% of our entire world population having diabetes, and this is the data from IDF back in 2019. But if you look at Malaysia, Malaysia records the highest in Western Pacific and one of the highest in the world. So it is certainly concerning for us being a very small country, but we are topping the sweet nation category, all right? So in 2015, we were at 13% in terms of our prevalence. 2019, we went up by 5%. But if you notice, from 2019 and another 2 more years to go, which is just 6 years away, we are almost doubling. So this is how slowly yet very rapidly the disease, silently but yet rapidly, the disease is creeping in our population, and it's affecting us in a very big way. Now, having said all this, right, the alarming rise of diabetes in Malaysia has a lot of impact. Let me just highlight a few to give you an understanding that, sometimes when you see patients and when you start treating patients with diabetes, we sometimes forget that how big this impact is to us in the end. Healthcare strain. We totally understand that, as number of patients increases, the healthcare resources that's required definitely increases, and that stretches everything. We end up using up resources that are necessary for other treatable conditions, or like infections or maybe autoimmune diseases, cancers, where they really require medical therapy. However, a lifestyle disease now has come into place and dropped the opportunity of them acquiring the resources. Number two, the economic toll. So as we have more and more patients with diabetes, definitely we need more and more people that are going to be involved in managing diabetes. And that spans from just not only an educator, a nutritionist, we need even the higher or the more specialized group of people like cardiologists, nephrologists, all these workforce demands begin to increase, and that increases our economic toll. Next would be family dynamics. This is a very, I know, a very basic point, but look at it from a family dynamics perspective. Just imagine if one of your family members happen to be diagnosed with diabetes and requires long-term follow-up in a clinic or a hospital. So they now will depend on you or probably other family members on commuting themselves to the clinic, going to get their medications, follow-ups, blood tests. That alone itself is going to be a high cost for the family. Emotional turmoils in the family will be happening if they happen to fall sick. So all these family dynamics also have a great impact. And that too can be a reason why the patient chooses to sometimes not follow through the advice that the doctor has given because it may not really suit their lifestyle. Thirdly, rise in complications. This goes without saying, as more and more diabetic patients get diagnosed, a lot more of them, in fact, fall into the microvascular and macrovascular complication list. Some of them, actually, most of them are diagnosed with already target organ involvement. Due to the reason, as I mentioned earlier, they delay, they see there is no need, it is a silent disease, they don't get ill until it's really bad. Next is what we can see outcome of these problems would be a public health push. So if you notice in the last decade, maybe we are seeing more and more health promotion. You are seeing more terms such as well-being, health, wellness. These kind of names are popping up because there seems to be a need that people need to be more aware on health itself. This is a lifestyle disease, which is definitely preventable to a certain extent if we are talking about type 2 diabetes per se. Yeah? And finally, education imperative. So we see the need for more health awareness education. And that's where even we as doctors, even though we are at the treatment level where we see people who are already sick, it is still very important for us to understand the stage of patients that we are seeing. Some of them you'll probably be seeing for another problem, but they are in the road to diabetes. So what kind of education can assist them to prevent them from getting there? That was in a very macro view. But now let's look at it from a pivot to a micro perspective. Now look, each and every patient has their own unique narrative. And many a times we as practitioners, we don't really get the time to understand the patient's background. What do they do? What do they really eat daily? What is their routine looking like? And for all you know, they are already struggling with a lot of things on a daily basis. Let alone the anxieties for future complications when you break the news that they are diabetic. So to be very honest, from my observation of things, even studies have shown that tackling the psychosocial aspects of the patient really assists and allays the physicians or the practitioners' difficulties in managing diabetes as a whole for the patient. So what I'm trying to say here is you've got to look beyond just the numbers. When you see, okay, you know very well this is a diabetic patient, maybe newly diagnosed, and then your journey starts now. There's so much the patient needs to know about this problem. But first of all, you want to take a step back and first understand what is the patient capable of doing. So whether your advice later on, will it be jiving well with the patient's life? Let's say, for an example, you get a construction worker who comes in and was found to be diabetic. Is it really logical if you were to advise him to cut down carbs, to eat on time, to sleep on time? Because nothing of these things are within his control, essentially. They are all managed from a very central point. They have got a fixed schedule. They have got fixed food or diet already served to them. So if ever you want to make a change, it has to go to a central level of trying to make some changes. And how possible is that? Because your duty here is towards your patient. right? So when you start understanding the limitations the patient has, the struggles that they are going through on a daily basis, you will be able to kind of mold your plan. And that's what we call individualized or personalized treatment for the patient. Now, what does this all mean for us, okay, primary care physicians? Because we are usually at the front line and at the first point of contact, or perhaps the recurrent point of contact that they come to after discharge from ward. There are so many things that we can actually decide for the patient, and we essentially set the tone on the patient's journey from here onwards if we don't realize it already. However, these are the three main challenges we face as practitioners for those who are truly into managing patients with diabetes. We have limited time because there's so many of them. We've got other things to do as well. How do we now provide the best for each and every individual? Number two, we understand that there needs to be personalized care. And whenever the terminology personalized come in, individualized come in, or tailored care come in, that demands a lot of time, that demands a lot of planning, and also collaborative work with the patient. Thirdly is staying updated. Obviously now with, so many advancements, and every day when you look through the news or even social media, you get to see, wow, there's this new drug, there's this new treatment modality is coming up, and all this noise that's going around us might actually divert us physicians away from our track of managing patients' lifestyle first. So that's the focus of the session today. I'm going to just bring you all down a road of where we can look at some practical tools. As we dissect the concept of lifestyle modification itself, it eventually boils down to four important fundamentals. First of all, would be your nutritional choices, because we understand insulin resistance and type 2 diabetes is essentially a condition that develops over time due to a poor lifestyle, right? Or a specific lifestyle per se, I would say. And nutritional choices here would be the first thing you want to look at when you're tackling lifestyle modification. Just a simple meal diary or a 24-hour food recall can be the first step on how you want to move forward into understanding the patient's nutrition. Second would be physical activity. Okay, and when we say physical activity, many of us think about your 150 minutes of exercise, 30 minutes at least every day. That mantra comes about over and over, and you tell the patient who has never brisk walked in their life, never ran, never done any cardio activities, and you want them to get on their shoes and start running. So it seems to be quite a mismatch in terms of advice and also receptance. So physical activity can be largely divided into your exercise itself, okay, involving your cardio exercises, cardiovascular training, strength or resistance training, we call it, and mobility or flexibility training. So whenever someone says they want to feel healthy, these are the three components that has to be incorporated in their exercise regimens that they do. Another category of physical activity, it would be your non-exercise activity thermogenesis. It's called NEAT. So this is where it is exactly the opposite of sedentary lifestyle, being sedentary. So we always tell patients to try to move about as much as they can. For instance, we suggest to them that if you are going to be parking your car, maybe you park it a little bit further from your office so you get a chance to at least walk in the morning and reach your target goals for your step counts. Or instead of taking the elevator, why not you take the staircase? So these are actually very subjective ways on how you can get the patient to increase their NEAT. Of course, there are much more, complex and objective ways on you to calculate all those, but that's not really necessary. You're just trying to get them to move about a little bit more than they do on a daily basis. In fact, even as doctors, as practitioners, you could share with them how I increase my NEAT when I need to sit in the clinic for 6 to 8 hours, let's say. So the ways I do is I get up and I go to the door and call the patient myself. or I get up, I go to the room and I get it ordered myself. So in a way, of course, you've got assistance, but you make effort to get up and move about. And that alone actually has shown to be quite, how do I say, quite useful in the sense that it increases your metabolic rate. It increases the glucose uptake of your muscles in the body because your muscles are continuously doing something. They are working. Thirdly would be your sleep hygiene. So we often forget this part. In fact, even as practitioners ourselves, we are most of the time sleep deprived. But sleep hygiene here means having good quantity of sleep and good quality of sleep as well. So quantity of sleep really depends. You've got to understand the 24-hour clock and at which part of the day you are now going into sleep. So whether it matches your biological sleep regimen or not. If it does not, then you already know that is a risk factor that can eventually lead to the development of insulin resistance. Okay, so that certain things can be changed, certain things can't. But just by understanding the sleep pattern itself will give you an idea to how much more you need to support the patient in terms of pharmacotherapeutics or other lifestyle changes that they need to do. Next will be stress management. This is something that is not really discussed, always overlooked, yeah, and it's very subjective to a certain extent. So they can't be measured. They can't be objectively written as a score. Yeah. However, what you could do is have a scoring system or perhaps just a very simple questionnaire to ask the patient in terms of what is their anxiety level on a daily basis, or if they were to have any depressive symptoms. There is a DAS scoring that you can do, but that alone is very specific. Most of the time, people who come in with lifestyle related diseases they are generally very stressed people due to maybe their job, maybe their commitments, maybe their financial status, and now adding on to that a new disease that's being introduced to them. This is certainly going to just add up the stress that they already have. So, as a practitioner, what I can see here is I have 4 or 5 things that's pointing against me. And how am I going to take this case and make the best out of it and bring the patient out of this problem, or at least be managing the condition well? It's going to be a great, great challenge. So now let's look at how influential lifestyle changes can really be on blood glucose levels. There are many researchers that have been publishing on intensive lifestyle modifications. You can go through these research studies on the American Diabetes Association page, where they have published the standard of care diabetes guidelines. And in the first few topics that they cover on lifestyle interventions, there are studies, for example, your Look Ahead trial, that shows how beneficial lifestyle intervention can be. However, when we use the term lifestyle intervention, it is not the vague suggestion that we give patients like, Pakcik kena kurang makan karbo, kena kurang makan nasi, tak boleh minum gula. These are all very vague advice that we are giving patients. Now, when we say intensive lifestyle modification interventions, there has to be some certain guides, certain personalized health diets that we prescribe to patients that comes under your medical nutritional therapy. And that's how you get your dietitians on board. But most of us, we get our dietitians on board without really understanding what is the requirement of the patient. So, end of the day, what we realize here is there is a big, significant role of lifestyle intervention. It has shown that patients can not only lose weight, but they control their blood glucose level, and morbidity and mortality has been significantly reduced in a span of 8 to 10 years from the trials that they have done. All right. So depending on medications alone is never the best way to go with managing patients with diabetes. In the end of the day, what I can tell you here is that patient empowerment is very important. When you see the patient needs to be empowered that they can manage this condition. And how do they get empowered? They need to know where are their weaknesses. Same like you and me, if we can't measure something, we can't we can't improve it, we can't change it. Like our report cards, when we look at the numbers, if we don't know we are doing badly or poorly in a certain area, how do we know those are the measures we need to take to enhance that? So the first step for patient empowerment is for the patient to understand where they stand. And that is something that I feel that we are most of the time overlooking, and we only show them numbers. Numbers don't really translate into any form of understanding for the patient. Secondly is self-efficacy. So self-care, self-efficacy is a concept where the patient takes charge and they feel that I have to look after myself. And where does this come from? Again, this comes from the patient, but with the motivation and the trust or faith that the doctor, the practitioner has on the patient. Thirdly is collaborative work between the patient and the provider. So when they find that they can actually work along with you rather than take instructions from you, they actually get things done. So these are the three main pillars in terms of lifestyle changes that we want to advocate for patients. Patient empowerment that comes from the practitioner by giving them data points for them to understand. Number two, self-efficacy that comes from within the patient. And thirdly is the collaborative relationship between the patient and the provider. How does lifestyle intervention actually compare to pharmacotherapeutics? There is no one best choice, You can't say only lifestyle is better than starting a medication. Sometimes you see patients saying that, doctor, I want to go the natural way. I find medications not useful for me. I don't want to take them. They can injure my kidneys, and I just don't like taking tablets. It's okay. It's okay to hear that. And it's okay for the patient to say that. So it's most important is for you to acknowledge that the patient is still not ready for the journey of starting medications. But the positive point is that they are so open to try natural methods. And when they say natural, it means something that does not require them to consume anything from the pharmacy at least. Okay? Lifestyle modification has shown to be more superior to oral hypoglycemic agents when it comes to preventing someone from getting diabetes if they are in the high risk group. This is already a study that had been published and has shown that a combination between medical nutritional therapy, which is your nutritional part, your food part, physical activity, as I mentioned earlier, your exercise and also avoiding sedentary lifestyle and good sleep habits have shown to improve one's glycemic control more than oral hypoglycemic agents alone without lifestyle intervention. And today you probably can see on the internet, there's just so many other supplements that are being sold and peddled for people in the high risk group to take to prevent them from having diabetes. Now, these are all added costs because for all you know, the basics which cost nothing but your time and commitment can help you prevent diabetes. What about for diabetes patients? Let's say they are already diabetic. Can you go by saying that let's not do medications yet? Let's just go intensive lifestyle therapy. Well, it really depends at what stage the patient is at. If you have someone with a HbA1c of more than 8, let's say at point of diagnosis, who already has target organ involvement, let's say they have microalbuminuria or they have some form of kidney disease now, of course, lifestyle changes alone is not going to be helpful because they are already in the verge of developing more and more complications. So you need a tighter, more intensive control of the glucose levels to prevent glycation end products to develop on a constant manner in the body. And lifestyle intervention also has to follow through because importantly, with the medications, they need to alter their lifestyle so that their requirement for the treatment can actually be tapered down. So over years, we have been saying that, the term reversing diabetes, reducing the medications, it is actually possible. But it all depends on what group of patients we are dealing with. If they are just newly diagnosed with a new onset diabetes, no target organ damage, studies have shown that intensive lifestyle modification with a very low dose pharmacotherapy can actually help reverse the situation and also make them lose weight. If they are able to lose 10 to 15% of their body weight in the obese category. So these are very interesting data that we are looking at, because they actually they are taking a different road or step altogether from our conventional way of looking at diabetes, where you are diagnosed and for the rest of your life you have to be on treatment. That's different now. Pharmacotherapeutics, when are they useful? Of course, for newly diagnosed type 2 diabetics with lifestyle changes potentially being slow to take effect. Because lifestyle changes takes months to years for them to actually, get into the routine and be able to know what is best for them. But if they are able to do that in a short span of time intensively, there is this concept called the legacy effect. Okay, where intensive control in the initial stages, that effect lingers on until many, many years later in terms of preventing them from morbidities and mortalities related to diabetes complications. So over time, here and there, they can, eat something sweet, or they don't have to be so strict to their regimen because they have managed to bring down their average glucose readings to something that is very near normal at least. And the second group of people that you have to start pharmacotherapeutics would be those with monogenic diabetes, your maturity onset diabetes of the young, LADA, okay, latent autoimmune diabetes, and type 1 diabetes. Now, let's move on to the data part, yeah? Engagement is empowerment, and that spans across any field that we are talking about. If we want something to work, we have to get engagement. Engagement here means the person we are talking to, the audience that we are talking to, is talking back to us. Yeah. And here, when we're talking about diabetes patients' engagement, we are referring to the collection of data that we are expecting the patient to provide us. Traditionally, over time, we have realized that we are collecting so much of data. For example, the patient's renal profile, lipid profile, their urine albumin results, HbA1c, so much of data about the patient. But how come the patient is just not getting better, isn't it? Yeah, so I have divided it into two, okay? The continuous or constant data collection as one, and the periodic data collection that we have been doing over time. The first component, if you look at it, these are your self-blood glucose monitoring or your self-glucose monitoring methods. Number 2, exercise monitoring and step counters. Number 3, your food log or your diary. And number 4, your sleep habits. These are data points that are collected by patients themselves on a continuous or a constant basis. The other one on the right, you see, is the periodic data collection. And as its name suggests, you collect it at a periodic interval. At the time you see the patient on diagnosis, maybe 3 months later, maybe 6 months later, a year later. And if you put things together now, and I were to draw a graph with all these two data sets, I get to see now a bigger picture of the patient. That means at intervals, how the patient is faring. And the continuous and constant data part becomes the justification to why I see these results at their intervals. For instance, if I'm seeing someone with a body weight or HbA1c, let's say, of 10 at time of diagnosis, 3 months later, I see their HbA1c at maybe 10.8 or 11. Didn't really change, in fact, got worse, even despite seeing me in the clinic. So if I have the continuous or constant data collection together with the periodic data collection now, it makes more sense to me to why the patient actually has a poorly controlled HbA1c. I get to see their exercise routines or their step counters to see if they are sedentary by nature or not. I get to see their food habits. Yeah, what kind of food are they still consuming that's not assisting the insulin sensitivity of the body? I get to see their self-blood glucose monitoring. This is so essential because at points where they peak and at points where they are at their troughs, at the lowest, the average is always taken in the middle. So for someone who says that they are always hypoing or their sugars are always low in the morning, you wouldn't be surprised to see their HbA1c on the high side because they peak right after meals. So postprandial readings are rarely collected. And studies have shown that postprandial readings need to be fixed when you see a patient with type 2 diabetes. That's the focus. When you have postprandial readings that are high, your insulin starts spiking up and they go into a state of chronic hyperinsulinemia, but hyperglycemia still. Yeah. So that's the role of collecting data on a continuous basis and periodic. Periodic, not really a problem because when they come in, we already have a system that collects their anthropometric measurements and that also does their blood results. Of course, in the clinic, you also want to check their eye. You get them to see an eye doctor to see if they've got any retinopathic changes. And at the same time, if you don't have podiatric services, you could actually learn on how to do a feet examination. It's very simple. Okay, now I'm going to bring your focus to the first category, which is the continuous data collection, because that's where we all, scratch our heads and think, how are we going to get the patient to understand this and collect this data for us to help them later? So we can start off with a very basic food diary, or we call it the 24-hour recall. If we are with the patient in the room, we do a 24-hour recall, meaning to say, can you just run through in the last 24 hours what you ate in the morning? What was your breakfast? Did you what kind of drinks you had? What was your beverage? Any snacks in between? What were they? So you are now listing down for the patient and seeing, what kind of pattern this patient has. But what would be better is you give them a food diary. And how I always do it is sometimes they get very flustered, with the sheer fact that they have got to write so much of details of what they eat and they don't know whether they're writing it correctly or not. So we guide them again. The first step is you just write down the type of food that you take. The type only. So white rice, brown rice, fried rice, and what are the other dishes that you eat with? So if it's, let's say, vegetables, okay, just list down what are the vegetables you're taking if it's mixed veggie dish. After they have done it for a week and they're comfortable writing it and they've got the format all good, then we graduate to the next step, which is the quantity of food. Now, this is where the problem lies because many of them actually can't quantify food. And we as doctors actually also don't understand how quantity of food work. How does this relate to calories? So what does 100 grams of white rice mean? What does that mean to me, right? First of all, get them to document the quantity of food based on the measuring tools that they already have at home. So if they have got a sendok nasi, a standard sendok of nasi, okay, that comes in the notes section. That becomes 1 unit. So 1 unit of sendok nasi. And if you were to Google it, okay, 1 standard unit of rice spoon is how many grams is already given to you. So you know the measurement for that. Why is this measurement so important? Is because later on, they are going to graduate to calorie counters. And this is how calorie counters work. You actually, to be very honest, you don't need to get a very high-five fitness specialist or a nutritional specialist to understand this. These are freely available applications that are in your devices. And what they do is they're a calculator. They calculate for you the total amount of calories that you take in a day. Why is this important? Is when we are going to do the intensive intervention life change for the patient, we are going to set goals for them. Now, before setting the goals, we must first understand where are they standing. I can't tell someone, you aim for the sky if they're still at the ground. So I have to tell them you first aim here and then aim a step above and then reach the sky. Similar goes for us as well. When we want to manage the patient, we have to set a goal for ourselves. If we understand this patient has got no background understanding of food at all, then we can't aim a perfect HbA1c in the next meeting. We can aim for a decrement, but aiming for it to be normal again is going to be very difficult. All right. So this is an example of how a calorie counter would look like in one of these apps, in any one of these apps. So the first one up here is MyFitnessPal. I think it's very famous. It's even discussed in studies and research that they have gone through how useful this tracker is. It's freely available. Second one is Healthify Me, and third one is Calorie King. These are just examples. You may even come across much more newer ones or others that can help count the calories for patients. This is an example of how, let's say, if they had keyed in their food that they have eaten. The food choices are available in the list of food that's provided for them in the apps. And some apps even have barcode scanners. So they scan the barcode of the food and the exact calorie or sugar per serving comes out. And that reflects on what the patient has consumed for that particular meal. A more advanced ones using AI technology even has scanning the food itself. But that's still under research to see how accurate that is, which means that if I were to scan a nasi lemak plate, right, it can tell me how much of calories this contained by just looking at the meal. So that's driven by some artificial intelligence technology. But I can assure you over time, that's probably going to be the way how we're going to calculate food content so that it stays standard. So this is an example. If you can see the first line, the macronutrients that are being documented, your carbs, fats, protein, sodium, and sugar. Why sodium and sugar? Because they are the important ones we want to look at in terms of blood pressure and sugar management. All right. And then you look at lunch. Similarly, what is being keyed in. At the end, if you look at the bottom, just like a balance sheet, I always look at calories as currency. So how much you have been given a day to use. What is your allocation? So your allocation is calculated based on your basal metabolic rate, your requirement, your age. There are specific tables that are available on guidelines. If later on you all are free, you can go to my Scribe. I write a blog on diabetes and ways that the patients can manage their diabetes. So there are actually tables where it is age adjusted with their gender adjusted and their activity level adjustment. If that is their activity level, this is their age and gender, this is their daily requirement of total calories. So total calories is your currency for the day. And you have to utilize the total calories within that day. If you spend more, you're going to be on a negative, which means that you're not going on the right direction. If you spend less, that means you're going on a calorie deficit. And that's the first step of actually losing weight. So the challenge here is being able to balance calorie deficit with nutritional intake. Many at times when we go on long periods of fasting, like intermittent fasting or just fasting per se, because we do just want to cut down our weight, we sometimes devoid our body from good nutrition. And in the long run, you can go into a nutritional deficiency state. So managing that is important. At the bottom, you get to see the total tally of how much of carbs you had that day, fats, protein, and so on and so forth. So this is the first step of actually moving into managing your nutrition. Okay, so I'm just going to end it here for the food part. Of course, it goes into more detail, but just to give you an idea that something that's not measured, you cannot improve. Next, let's go on to glucose monitoring. Okay, so this is the other component of your continuous and constant data collection that we want the patient to collect for us. So there are a few ways on how the patient can actually monitor their sugar on their own, either through a capillary blood glucose test, which is your finger prick test, the conventional typical way that we do. But nowadays we have a little bit more advancement and they have been showing quite remarkable improvement in terms of preventing hypoglycemic effects as well as improving the patient's HbA1c in the long run. I personally think that this has been the game changer in terms of patient empowerment because they are able to look at multiple data points in a day without tricking themselves, obviously, and they get to understand what food spikes up their sugar. Okay, so Flash Glucose Monitor is a device that's available in Malaysia, in fact, and there is a study that has been done in Malaysia comparing flash glucose monitoring with our traditional blood capillary blood glucose test. The discrepancy is seen at about 5 to 15% at max, but they are quite representative because flash glucose monitors and continuous glucose monitors, they monitor the interstitial fluid glucose levels. Okay, so flash glucose monitor, how it works is that there's a reader and there is a sensor. So the set that you buy contains a sensor and a reader. And each time you tap the reader to the sensor, the reader gets the reading. Over time, it is used for 2 weeks. The sensor lasts for 2 weeks. And after you could actually translate the data to a graph immediately, or you could do it after a week or 2 weeks. So once that's done, that data set can be shared with your physician or practitioner, or you yourself can have a look at it and try to understand how this fluctuation of sugars actually happen in your body. In a way, you get to understand your body much better. You get to justify to why you were feeling tired at this time, why you were feeling so energized then, you were feeling sleepy at this period. And this has really worked for a lot of people who are lay people, they're not doctors or with any medical background. How about continuous glucose monitoring? Now, this is real-time continuous reading. So the device, that's also a sensor, and you could actually use an application in a phone, or the reader itself continuously collects data of the sugar that's being read. And if for type 1 diabetics, now they have the CGM automated closed loop, where you have the CGM that actually connects talks to the insulin pump as well. So as and when the sugar drops, the insulin is stopped by the pump by itself. And when the sugar spikes up a certain level, then the insulin is delivered. So that's the closed loop system. Well, they are quite pricey, but if we were to compare cost-wise, a capillary blood glucose test in the initial intensive period of monitoring, let's say, the patient is going to spend almost the same amount for the flash glucose monitor. Because let's say if they're going to buy the device, they also have to purchase the lancet and the strips. Yeah. And in the first 2 weeks of intensive monitoring, for you to understand where the patient stands and what kind of readings they produce, you are probably going to spend close to about 400 to 500 ringgit, including the device itself. Okay. However, for flash glucose monitors, they come in the range of 500 to 600 ringgit. The sensor plus the reader itself. The reader lasts for 2 weeks. Yeah. The sensor lasts for 2 weeks, and the reader can be reused again with new sensors. The plus point to this is that you could check your sugar at any time by tapping it. Yeah. And it is comfortable. It's not painful. You could bathe with it. Plus, you only stick on your skin once, and there's no pain at all. So though for those who, they don't like to prick themselves, it is definitely painful, or needle phobic and all that, this could be a good option for them. However, for those who are, financially constrained and they don't mind using the capillary blood glucose monitor test, no problem at all. Go with it. So we will see how we can empower them with that reading. Now, then comes the question, how do we decide how frequent to monitor these readings? It really depends on a few factors. There is no blanket rule for what is the SMBG frequency going to be like. It depends on their willingness to monitor, their lifestyle and schedule, their physical ability, whether, are they even capable or not to check on their own. Of course, their financial limitations you have to take into account. Their medication regimen, if they are on insulin, of course, you would want to propose a much more frequent monitoring if they're not stable yet. Looking at their glycemic control, if they are very well controlled, then you can cut down the frequency of monitoring and the type of diabetes, obviously. So here are some guides, all right, on how you could decide on your SMBG frequency. We have the 3-point monitoring system. Where do we get all this information from? Well, you can find them on the NHS guidelines for self-blood glucose monitoring. And there are recent studies that has also been done in terms of comparing SMBG with CGM and FGM readings. And it has shown that in the intensive stage of lifestyle modification, to collect data on a diabetic state, your HbA1c and FBS intermittently is not sufficient. And when we advocate SMBG for the patient, we actually have to be clear at what point of readings are we looking at, so that they are not lost. So here the 3-point monitoring system is we take pre-breakfast, that means after a fast overnight, pre-dinner, post-dinner. This is an example. This can be used for patients who are on twice daily basal or mixed insulin, or for those who are newly diagnosed type 2 diabetics, just to get them used to the system that this is how you're going to be monitoring your sugar. It is quite counterproductive for someone who's newly diagnosed and for you to start a very, very tight regimen for them. They are most likely going to default that. Next is the 5-point monitoring system, just a graduation of the 3-point, where if you think you find that this person's control is not good, HbA1c quite high, maybe more than 8 or 10, needs quite a tight control in a short span of time, then you could ask them to check 5 times a day. A 7-point monitoring. Now, this is usually for those who have gestational diabetes, or those in their preconception stages, maybe overweight, has got risk factors for diabetes. Those type 1 diabetics, or those who are on basal bolus diabetes, basal bolus insulin. They take that 3 times, and then they also have their basal. We also have the staggered monitoring system. These are for your very difficult patients. I will say that, I really cannot find time. I'm so busy. And yeah, I always forget. The ones who are the frequent defaulters, guess what? They also have a regimen for them. Okay. And you could try the staggered monitoring system. So how you decide on the staggered monitoring system is to actually just very quickly do a lifestyle, screening. Ask them what they do every day. What's their job looking like? When is their free time? So you don't want them to be forcing themselves to check something when they're in the midst of something very busy. This includes doctors too, So if you take, for an example, a doctor who's very busy working and also diabetic, how do we counsel them for a staggered monitoring at which points of their day? So you've got to understand them just a little bit better. Or those who are on shift schedules as well. And lastly, if you are suspecting someone having, very high sugars in the morning, their fasting is so hard to control, then you could do the fasting hyperglycemia check regime. You want to know bedtime, what was their reading, and pre-breakfast, what is their reading. This also could help you in your Somogyi effect if you want to see if the patient has Somogyi effect. Okay, when there's too low blood glucose level during your bedtime, there is a surge in your blood glucose in the morning. Okay, now we are done with going through how do we collect data for food, how do we collect data for glucose. Of course, exercise data is another whole session now. Perhaps maybe in the future we could discuss that, or you could just follow my socials. I share there as well. I'm just going to share with you a sample profile of my patient. She didn't really try any hi-fi, she didn't use any hi-fi devices or applications. What she basically did was used a Google Sheet, and she recorded her blood sugar levels, her medication that she's been taking, and her food log. A food log here, the amount and all that, she went into measuring the amount that she takes. That was a little bit intensive, and that related to how many calories. So that was also calculated through a basic calorie counter that was found on Google. Okay, and then she keyed in. At the end, if you can see, it's quite small here, but at the end of the column, you can see exercise, how many steps she did for that day. Now, the final part, which is health data integration. So how does all this information matter to us as physicians? You can see that the first picture on your left, that is the steps. Okay, this is actually an application that's readily available that connects whatever devices you use, or it connects to your food app, your food tracking app. The bare minimum is you could just suggest to your patient, if they are capable of getting a device that's able to track their steps, maybe very basic measurements of their body, like their BMI, that can be keyed into the app. So it tracks your BMI trend, and your heart rate, your sleep pattern, and some more advanced ones even have your stress management level as well. Like, the whole mindfulness thing is also within that ecosystem. That's at a very high level if the patient is using an Apple-related device or so. But otherwise, you could use anything that just collects the data for you to see. And the one you see on your right is an example of a blood glucose profile that has been recorded using a flash glucose monitor. So if you look at the picture at the top, it gives you a summary of that 14 days. What is the percentage of the time that the sensor was actively collecting data? You can see the average glucose. Okay, that is your other glucose management indicator. We call it GMI, which is another form of your HbA1c.
it is somewhat said equivalent, maybe very slightly different by 5% or so, but it can be a reflection of the last 2 weeks. What is your average glucose reading? Somewhat like your HbA1c that you see every 3 months. But of course, that's more specific because it measures your glycated hemoglobin levels. And you get to see your variability. That means how much does the sugar fluctuates in the day. If the variability is high, you definitely know that this patient's glucose control is not good, despite the HbA1c being just 7. You get what I mean? So you get to see the pattern. And then you get to see on your right side, the time in ranges, TIR we call it, where how many percent of the time the patient is within target range and how many percent of the time they are off target range. And when you say off, is it too much more or too little? At the bottom is what you see in terms of graph. So the bottommost graph is the daily glucose profile. So the ones in yellow is basically the ones that have exceeded the normal range for the day. And you get to see how often that happens. You get to correlate with your food. So that's why pairing your food diary together with your glucose readings is just so important in the intensive phase, the first maybe 2 weeks to 1 month of intensifying the patient's glycemic control. And if you see the graph in between, that really tells you that how near normal has the patient's blood glucose been throughout the 14 days of measurement. So this is, a very simplified way on how you could integrate data put together. We have come to the end of our session. The key takeaways, what I want to share with you here is that managing diabetes is just not the number alone. Yeah, we have to go beyond the number. Of course, setting goals based on numbers is essential. And again, coming down to individualized targets is another thing. You have got to see so many aspects before you fix the HbA1c target goal for the patient. Not everyone needs less than 6.5. Yeah, go through the latest guidelines and see that a newly diagnosed diabetic adult, okay, if they do not have any complications of sort, yes, and in their first 10 years, you want to be a little bit tighter with them. Or else pregnant ladies also, you want to be tighter. Older adults, you can be a little bit more lenient. Next thing is power of basics. Now, so going back to basics again, how useful those tools are and how you can use technology as an ally. In the 21st century, we don't want to fall back. We want to leverage on this. And lastly, understanding that managing diabetes in their journey with the patients are setting evolving goals. It's not one goal for the rest of their life. So you've got to understand the change of their goals. These are my references. I generally take them from our American Diabetes Association guidelines, also including the clinical practice guidelines of Malaysia, and there are a few other recent studies in terms of diabetes technology. So that's the end. I would like to open the floor for questions. I see there are a few questions here.
Yes.
Okay.
Yeah. Doctor, you can read and then you want to answer it yourself?
Sure, no problem. So I have question 1, Dr. Azrul, one moment. Just want to share patient with sleep apnea at risk to get DM type 2 as well. Check for sleep apnea and for those with risk factor and refer to ENT for sleep study. Maybe Dr. Lavanya want to share her thoughts on the comment. Absolutely right. So in your assessment of a person with diabetes, it is so very important because it's a metabolic disease. You want to know, these are the more knowledge related part lah. The diabetes is associated with lifestyle on what sense? Is it mainly due to the food that they are taking, or now they have got another risk factor, which is obesity, that leads them to obstructive sleep apnea, which eventually also serves as a cause for insulin resistance. So again, you have to boil down to the main cause of the patient's problem, and that comes with assessment. So for a doctor with a good clinical acumen, when you see someone who's obese, who's overweight, you immediately think of, oh, this person could also be suffering from OSA. So as much as I intensify their pharmacotherapeutics, it's not going to be very helpful because obesity itself is going to keep them having insulin resistance. So weight loss is going to be my main target goal for them, on top of managing their impact glucose tolerance if they are not diabetic yet. Thank you very much for bringing up that point, Dr. Azrul. Appreciate it. The second question we have is there specific shop Oh, who sell flash glucose monitor, never seen. Actually, to be honest, the flash glucose monitors that I recommend for my patients are monitors that they are buying off the counter in large pharmacies. Yeah, and most of them are available in urban areas. Okay, urban areas, even in Sabah, Sarawak also ada. Okay, urban areas, I wouldn't mention the exact name of the pharmacy, but large pharmacies, what you could do as doctors, right? I usually call into the pharmacy and I ask them if they have a flash glucose monitor of whatever brand, not any particular brand, but if they have an FGM available. If they do, then I will provide that option for the patient and they would go themselves and look into it and buy. And in terms of how to apply it and so on, of course, when it comes to tech, you have to make sure that there is training and resources provided for the patient. Training and resources, you can do it hands-on. That will be one of the best way, but never just end it with hands-on. Always connect them with some link or resources that is ongoing. That means they can go back and they can refer to it again, either a video or some content online that they are always able to refer to. Okay.
Okay.
Yeah.
I have a question for you, doctor. Okay, based on your clinical experience, right? Of course, if the patient patient want to change, when they newly diagnosed diabetic, you want to have a change. So therefore, they would follow. Okay, I want to change for my diet. I want to change for my lifestyle. So therefore, this kind of group of the patient would certainly give you the data that you need. Right. So in your clinical experience, right, how difficult or how easy that you're able to obtain the data from the patients? I mean, in terms of, yeah.
Oh, I must be very honest with you. It is very difficult. Yeah, it is very difficult. But the reason why it's difficult is this multi-pronged. Number one, the collaborative relationship we have with our patient. Many at times when we see a patient with diabetes, we start everything for them and all that. Then they go to another doctor. Then they go to another doctor. Or they see another doctor. Then we lose that connection with them, that journey with them. That's one. So how do I keep it going? How do I keep it going? I try to use as much communication online as possible. So those who are in their own practice, that's a little bit easier, I would say, because if we're going to talk about systems and if it's going to be clinical practice and government service, then we've got to look at the large system, how the system itself is going to connect with the patient on a large scale. But if it's a one-on-one thing, setting appointments with patients online for them to deliver their data to us, for us to do a brief interpretation and provide them a response. So I actually have devised templates, systems that kind of automates itself. It's not largely available out there. It was just like, a trial and error basis where I want to find ways on how I can get data from the patient on a timely manner. And these were one of the ways. Another thing is that if they are affordable, if they are able to get devices that can log data, that means they don't have to key in and send it to you actively, you could use that platform to kind of, if they share it once with you, you get to access their data. And this is after they have formally agreed that they want to share these data points with Dr. So-and-so. So you get to see, you get to feedback with them. Yeah, so yeah, that's how I do it.
Is it that apps is available? I mean, that kind of system, is it available in the market? I mean,
you will laugh if I tell you, you will laugh if I tell you, I use Google Sheets and I collaborate with the patient, okay? That is for them to manually enter. But for those who don't manually enter, there's other apps called ZapLife. I don't know if you all have come across it. ZapLife, Google Fit, yeah. Depending on what platform they use, there's always a fitness app that is built into it. Okay, just check out Explore Fitness apps and see their shareability, to what extent you get to see their data points and how you can assist them in that area.
Okay. All right, we don't have any more questions, doctor. Do you have any, because the way we're looking at managing a patient with diabetic or pre-diabetic of course, the gist of it is the same, but it's just that the way that the practitioner going to do for the patient as a part of preventive strategies now is a lot more. as what I've understood from your lecture, right? So it's a lot more. So therefore, the time spending in a consultation with a patient has become, you definitely take up a lot of time, right? So what do your advice to the GPs, to the clinic medical officers out there in terms of, when it comes to diabetic management in their
That's a very good,
settings?
that's a very good question, because I did mention that one of the limitations we have is time, isn't it? So how I see it's going to be doable or feasible is that you have to refer them to resources that are authorized. We have the Diabetes Lifestyle Program. That is a nationwide program conducted by Ministry of Health, MEMS, MDES, and FMS Association. It is running continuously since 2020, if I'm not mistaken. So if every GP who's managing diabetes could sign up as a diabetes lifestyle advocate, you get access to a lot of resources, what you could provide for your patients, and resources even for doctors on how doctors can advise patients on certain things like sports medicine and things like that, right? So that is a very good platform that I would like to suggest. And I myself is a DLP advocate. So I went through the program. It's very super useful, right? It really helped me a lot in my practice, number one. Number two, you have to be resourceful in the other sense where link the patient to videos or content that's existing online that is valid and reliable information. All right. I try to avoid sending them to TikTok channels and all that, because it's very brief, very short, not enough for them to actually have a deep understanding on things. So if they are able to do that, they come and see you, they already have some base knowledge. Your time with them is only to debunk certain things and clarify certain doubts. And my consultation usually doesn't exceed 15 minutes for my diabetic patients already.
Okay. All right. Oh, there's another one. Doctor, what is your opinion about artificial sweeteners like stevia?
Okay, that's a good question. Actually, I did come across a paper that was talking about artificial sweeteners. They do have an effect in terms of increasing the patient's glucose levels to a certain extent. However, the replacement it provides is the sensation that it is sweet enough, replacing sugar itself. In the long run, it does not seem to be as useful as we think in terms of bringing down the glycemic index of the patient. And this is not only in the research, but I have personally observed it in people who only use artificial sweeteners for years, but their sugars don't budge at all. And I believe if at all it helps, it's a very small part of their life. It doesn't mean that if I go on artificial sweeteners, I can whack all the burger out there and I can have everything that is also high calorie food So that is why sometimes patients come and ask, but I'm taking stevia, why my sugar is still high? So this doesn't work, is it? It's because their overall understanding about the calorie intake. So whatever sweetener you take, just look at the calorie intake of it, how much of sugar it contains.
Yeah, that's right. And of course, laymen would probably by now they would know that carbohydrate translate to sugar.
Yeah.
So yeah. All right. I think we don't have any more questions. So we have total 244 viewers for your lecture, doctors. So thank you very much. Yep. So thanks to all the doctors that attended the meetings today. Thank you very much. Thank you.
Thank you, Doc Witty. Thank you, doctors, and thank you, Miss Louis. Bye-bye.